Good afternoon, everyone. The Gloria is amazing. She gets up there without one note card, without one anything, and just goes, and she just goes on and on and on and on. I can't do that. I got to have slides. I got to hide behind this podium. And actually, I'd be even more comfortable if like the light were off, so you could hardly see me. But I want to talk about something, and I want to talk about something important, something serious. Serious because it can happen to anyone. And also serious because just like HIV, it is mostly preventable. And I want to talk to you about it. Well, that don't work. All right. That's colon cancer. Cancer of the colon and the rectum. And the rectum is just the end of the colon, just before the anus. It's the fourth most common cancer, 150,000 cases a year in the United States. Second leading cause of death, more than 50,000 every year. But there's a point I want to make now, and I'm going to make it 3 or 4 or 5 times during the talk. And that is your chance of being cured is much, much higher if it's found before you feel anything. Now, the number of people getting colon cancer has been going down actually for a couple of decades. And that's been related to advances in doing screening, prevention. But the improvement has sort of plateaued and it's lagging. And it can and should be better. I'm going to talk to you about how that comes about, and then I'm going to ask your help. So I want to start with what they call an overview, an introduction. Who gets it and how you can prevent it. And you see, I say why, who, when do you start, how do you do it, how often do you do it? And then I'm going to present something, not research from around the world, but from research that's done at Jacobi and at North Central Bronx Hospital, the 2 hospitals where I'm at. These came from actually trainees, interns, and residents who decided they wanted to do something and came to me. And even though I wasn't so interested in colon cancer, I was more interested in HIV and hepatitis C, and that's how I got to be involved with COPE. Well, I got involved with colon cancer, and we looked to see about colon cancer at Jacobi and colon cancer at North Central Bronx. And that's really important because colon cancer in Minnesota doesn't mean a whole lot to us, right? Colon cancer in Europe or Australia doesn't affect us at all. Colon cancer in New York affects us a lot. Colon cancer in inner city neighborhoods affects us a lot. So that's what we studied. And it wasn't a study to prevent colon cancer because we're in a hospital and we don't see people until they come in. But short of preventing colon cancer 100% is making a diagnosis before it's incurable. And that's what we looked at. What are the reasons why somebody who comes in and we diagnose colon cancer, it's in a state that's almost incurable? And then I want to talk about an initiative that started at Jacobi and NCB as a prelude to colonoscopy. That's testing of stool, non-invasive. You don't have to take a clean out. You don't have to be put to sleep. You don't have to have a tube shoved up your butt and moved around and whatever. Even though it's like you get through it. And you actually get through it. It's not even all that bad once you've done it. I've done it a couple times. So I know. but this was done in the clinics. I want to tell you about the early results, what was good about it and what was bad about it, and what we have to do to try to make it better. And at that point, I'm going to ask for your help. How we're doing things, my suggestion as how we would do things or should do things for people in the community. But how the hell do I know what people in the community want? But you're people in the community. So maybe you can tell me. And I can bring that back to Jacoby for the next time we do stuff, which is soon. So let's start with a couple of misconceptions. The first is that the problem of colon cancer is just getting worse and worse and worse. The second is that the major problem in colon cancer is that it's happening in really young people. The third is like nothing you can do about it because getting colon cancer, the risk is just inherited. And there's just nothing you can do about it. The fourth is the opposite. As long as you lead a really good, healthy life, right? Do all the things that are good for you, you won't get colon cancer. And then the fifth, which is like the hardest it seems for people to understand, is that there are two possibilities. One, or there are actually 4 or 5, but two major possibilities. One is you could have a colonoscopy, or two, you could do a stool test, and you get to choose one or the other. What would you choose? Well, you'll find out what I think. All right. All right. So why should? Well, it will show if you have advanced polyps, right? And you'll hear when I talk about it how important that is. So why should we do this at all? So we start with and don't mind me if there are a lot of words. Just try not to look at the words. You can sort of look at the graphs and whatever. I have the words there for me, not for you, so I can not forget what it is I want to get across. Between like 1920, when people started looking, in 1970, the risk of getting colon cancer was just going up and up and up, and people thought it was due to changes in diet or whatever. And then around 1975, people started doing colon cancer prevention, looking for blood in the stool, doing sigmoidoscopies, because a lot of the cancers were pretty low down. And if you just look at like this far in, you could find a bunch. But by the 1990s, people started doing colonoscopy. And you see, well, I don't see. Well, by the 1990s, then on, the numbers came down, really came down. Red is women, blue is men. And it came down in both. I don't know. But in fact, in much of the country, men are a little bit higher. So this is information that was gotten at Jacoby and NCB in 2016 to 2017. And they were looking at the stage of cancer, 0 being hardly any, and 4, the IV, being spread to the liver or wherever, to the point where you can't cut it out. And we looked at 2 different kinds of patients, one who came just for screening, and the second are patients who were already sick with something, change in their bowels, bleeding, anemia, weight loss, something. pain. And if you look under screening where it says 0, 1, and 2, 94% of the patients were either 0, 1, or 2, which is curable more than 90% of the time. Whereas if you look under diagnostic, you see more than half of the people are 3 and 4. And 3 is when it's spread to the lymph nodes, to the glands. And 4 is when it's spread to the liver or the brain or the bone or somewhere else where you can't get it out.
So how do you prevent that early diagnosis?
Early diagnosis, yeah.
I have a question about comment about the stool test.
Yeah.
You said about taking something back to Jacoby. My doctor had asked me to take a stool test, and I did it. The next time, the nurse wanted the stool test, and I refused because I thought it was because she thought I was having no sex, and I'm a heterosexual. But I'm just showing you how ignorant I was. It had nothing to do with sex. She was looking for cancer.
Right.
So I'm just showing you how a man
right.
thinks.
And you should know, and I'll get to it, but you should know, just to answer your question, if you go and have a colonoscopy and it's negative, you don't need another one for 10 years. On the other hand, if you do a stool test and it's negative, you need another one the next year because the colonoscopy is way more sensitive. But the stool test is not bad. And if you really don't want to have a colonoscopy, all right, you do the stool test. However, if the stool test is positive, you can't stop there. So then you need a colonoscopy. So whoever answered my question before said both. Yeah, it's both, but not in everybody. If you're negative, you're good till next year for the stool test. If it's positive, you should have a colonoscopy.
AI help doctors find more. I was wondering if anybody's using AI.
AI doesn't make you find more cancers because cancers are so obvious that you just have to look. AI is for these tiny little things. And either they're tiny little polyps that may grow, but you don't know, or they're like nothing. All right. And AI may help you to decide whether you need to take out every little thing you see or you can leave it.
Yeah, they were saying in an article, they were saying that most doctors miss what AI detects.
Yeah. What's helped more is getting colonoscopes that are much more sensitive, like a difference between a 56-inch TV and the old 13-inch TV. All right. The 13-inch TV, you can see big stuff. But with the big TVs, you can see somebody if their nose hair is too long, right? And that's really what's made the difference. And the other thing that's made the difference is that people are trained very well. I know I run a training program. All right. You got to do hundreds during your training with people supervising before you're let loose to do it on your own. Yes.
Even though they didn't find no power, they did it with contracts. I'm gonna have to repeat it in 5 years.
All right. So the question is why, if you're negative, why do they want you to come in 5 years? It appears that some people make polyps and other people don't. All right. And once you've made polyps, that means you're at risk for making more polyps. And maybe the polyp was there, but it was way too small to see. And if you wait 10 years, by that time, the polyp will not only grow bigger, but turn into cancer. All right. But it's all odds. You know what I mean? You can't be sure. You can't know if you haven't seen it, whether it could be there or not, because you can't see it.
And I work for some of the health medical services. One of my patients
took a colonoscopy, 7 months ago. And before she left, they called her in and said that she felt so dirty and she had to take another one. And she didn't understand the reasons. And I don't think it's many.
Okay, so, dirty and you need to do it again, usually tomorrow, or with another whole prep, or sometimes 6 months because it was dirty but not too bad. It's like, in order for a colonoscopy to work, you can't have a lot of shit in your colon because you can't see through it. The colon's got to be emptied out. All right, and some people just don't do a very good job of emptying out, or some people empty out their colon and then they eat dinner. All right, so by the next morning, there's stuff that's back in the colon. So she wasn't completely prepared. So they didn't get a good enough look. So they said, no, we got to do it again. And if it's really bad, it's like, we got to do it again tomorrow, or we got to do it again soon. Yeah, Myron.
Yeah, let me ask you a question. The doctor is outside on the. Doctor told me that is, I'm going to compound to be 10 years next year. But Mount Sinai has a policy that they will not do a compound if you're sending. And they will not do
I'll get to that, but the point is that, but if you come in to the hospital and you're passing blood in your stool, they'll do you tomorrow. All right. The older you are, after some age, the risk goes up. But if you've had 2 or 3 or 4 and they've all been negative, well, the chances really are that the 5th one will be negative too. So therefore, you're 83 years old. Why would they take the chance of harming you? All right. On the other hand, there were 2 studies, one from France and one from Japan, where they did the stool test. And if the stool test was positive, they did a colonoscopy. And they had a very high yield. They found that a lot of people have cancers. Your risk of getting cancer goes up over your lifetime. The number of cancers when you're really old actually goes down because the number of people who are really old go down. But you know what? I'm going to get to a lot of this. So if you let me go through it a while, I may answer your questions before you ask them. So what are the options? One is colonoscopy. And if you've had polyps or if you've had a cancer, you should have a colonoscopy. All right. The second is a stool test. And the one that's sort of the cheapest and used most is the fecal immunochemical test, where they actually test for blood in the stool. Now, if you have hemorrhoids, you may have blood in your stool. So a positive test doesn't mean you have cancer, but the risk of having a cancer is higher. The third is where they look in a little bit and then do a fit test at the same time. But you still got to do the same clean out, so hardly anybody does that. The fourth is this multi-targeted fecal DNA with FIT, and that's the one you see on television with the box with the legs, who like walks around and talks to people. And there they're looking for actually genetic material that's released from the tumor. And the fifth is some X-ray thing where they clean you out and they put air in you and make you really distended. And then they do a CT scan. Now, the problem with the fecal immunochemical, the sigmoidoscopy, the DNA and whatever, is that if it's positive, you have to have a colon. Because they got to find out exactly what it is, exactly where it is, what it looks like on biopsy, etc. But if it's negative, it's negative. Well, then who should get it done? And it kind of depends upon the natural history of colon cancer, whether you've had inflammatory bowel disease, and your family history. Typically, we start at age 45. And typically, we stop at age 75 unless people are pretty healthy, and especially if they're pretty healthy, but they've had polyps. Because if you're 82 and you get a colon cancer, it's just as bad as if you're like 55 and you have a colon cancer. And death can be awful. And if you can prevent it and you're healthy enough, well, why not? So between 75 and 80, it's sort of the doctor's choice based on how healthy the patient is. And then after 80, we tend not to do it. Although in my personal experience, I would do the stool test because I've seen too many 85 and 90-year-olds who have cancer. And the thought that they may have cancer and doing nothing seems stupid. All right. And then this whole thing about family history, and that's risk stratification. If your father had colon cancer, your risk is doubled. If your mom, right? If your brother or sister, your risk is double. And you should start earlier because you may have inherited that same predisposition. Now, if you have 2 or more people in your family, father and brother, mother and her 2 sisters, and they all have colon cancer, well, then, there's a risk that there really may be a cancer syndrome in which half or all of the people in the family are going to get colon cancer. And then you start way earlier and you do it way more often. Because some of those cancer syndromes don't take 10 years to go from a polyp to a cancer. It would take a year or 2. Uh-huh.
What is the definition and the symptom of inflammatory bowel disease?
I mean, ulcerative colitis or Crohn's disease? Chronic inflammation. And chronic inflammation of many types can lead to cancer. The inflammation you get in your lungs from smoking can lead to cancer. The inflammation that you would get in your lungs from tuberculosis, poorly treated, can lead to cancer. The inflammation that you may get with infections in the cervix can lead to cancer. So if somebody has inflammatory bowel disease and they've had it for 5 or 10 years, their risk of cancer goes up, even if they're only age 35.
Or which one are the symptoms? What symptoms?
It's the same symptoms. The symptoms can be bleeding, or its stools become narrow, or you suddenly become constipated, or you suddenly develop really lower abdominal pain, right? There are a number of different symptoms.
Prostate and colon are in pretty close proximity. How often do cancers start in one and spread to the other and go common?
Colon is more common than prostate, although prostate's also pretty common. And no, even though they're right next to each other, they're 2 separate things.
So it's rare that they would spread from one to the
They don't. I mean, one in the colon can grow into the prostate
Yeah.
if it gets big enough. One from the prostate can grow into the colon if it gets big enough. But the same thing can happen with the cervix. All right. And in fact, the way women used to die of cervical cancer is that it would grow back and block the kidneys or block the ureters, and women would go into kidney failure. That's just a local spread. So you can have local spread, but they're 2 different kinds of cancers.
Yeah.
And whether you have one doesn't mean anything about getting the other.
You know, as for the mention about recommendations for treatment, because they heard from numerous times that at a certain age they don't recommend invasive treatments for prostate cancer, because they say usually it spreads much more slowly.
The older you are, yeah.
They said that the age becomes a risk factor.
Right. Well, there's another reason is that it spreads really slowly. And if you get to be really old and you really look hard enough, you can find a cancer in almost everyone. Okay. And during a lifetime, they have no symptoms at all. So it's like having pimples, at that point. Even if it's a cancer, it grows so slowly that, you follow?
Yeah, so they, like, I had fallen that died of cancer at 90. So I think when a person dies of cancer at 90, then basically, I mean, that was to me, that's
Right.
more than a normal.
But if somebody starts to have symptoms, well, then you should look. Because if you can't cure somebody, you can at least palliate. You can at least relieve suffering.
One more thing, you mentioned, women's cervical cancer. What about, correlation with, breast cancer? If someone's family, women have breast cancer, is there any correlation that the men develop as well?
Only if there's a cancer syndrome, and there's certain cancer syndromes in which you can get breast and colon. There are others in which you can get colon and kidney and uterus and ovary. You know what I mean? They're separate, different diseases, and depending upon what's wrong. All right. But most colon cancer is just colon cancer. All right. And it's not part of you may be predisposed, but it's not some genetic syndrome in which the whole family is going to get it. All right. They call that sporadic. Now, what do you do if like your first degree relative has polyps? There's an increased risk, but it's way smaller. So when should it be repeated? Well, if you've had colonoscopy and it's negative, you can wait 10 years. If they find one of these polyps that is potentially could turn into malignancy, you better have it in 5 years. If you have 3 or more, well, you may be actually better to do it every 3 years. Okay. And it's not really because you think that the tumor's growing, but that you find 3, but they're actually 4. And the other one you just didn't see because it's too small. And if you then wait 5 years, you may have waited too long. All based on odds. Now, if some of the bigger polyps are called advanced adenomas, and those are the ones you're pretty sure are going to turn into cancer. And if you find one like that, especially if you not positive you got it all out, you may say, I'm going to do it to you again in a year. Or if you've taken it out and you're not sure that you really got it all, you may say, I'm going to do it again in 6 months. So it then depends. But if you have that stool test and it's negative, it's every year. If you have the Cologuard, the one on TV, it's every 3 years. If you have the X-rays every 5 years, as long as it's negative. But remember, if they're positive, you should go for a colonoscopy. And now people are talking about a blood test. And they can actually find cancer in a blood test, but nobody's shown that you can prevent it. I didn't quite get to this, and maybe I'm missaying it, but if you do a colonoscopy and you find these pre-malignant polyps and you take them out, you just prevented that polyp from turning into a cancer. The same way a woman gets a pap smear and the pap smear is abnormal and they go to the gynecologist and the gynecologist does whatever gynecologists do and takes that abnormal tissue out, it prevented her from getting a cancer. Okay. So this whole idea about early onset colon cancer. You recognize Chadwick Boseman? Black Panther? All right. Died early because he had one of the genetic syndromes. Well, if you look at that chart on the right, the number of cancers in really young people under age 50 is the blue. Between 50 and 65 is green. And those others are sort of over age 65. Over age 65 or over age 75 or both. And it's not as bad as it looks because, in fact, these numbers have been going up. But compared to people older, really low. But compared to people who are over age 65, it's way low. And the point about the people who are over age 65 and have had this marked decrease in the risk of getting cancer is because they had colonoscopy when they were 50 or 55. And those pre-malignant polyps were removed. And then they had surveillance. And we made sure that that new polyps weren't forming. And then the risk of cancer goes way down. So the number of absolute increase in cancers has gone up in 42-year-olds. And in fact, last night, the guy on call had to do an emergency stent placement in a 31-year-old woman with colon cancer who became blocked, and there was the fear that she was just going to blow out. So yeah, it absolutely happens. But those numbers are way lower than people our age. So there have been a lot of studies done about risk of colon cancer, and you can see this whole list of people strongly increased risk, or moderately increased risk, or modestly increased risk, and things like a lot of red meat, or if you had radiation to your pelvis, like you had, cervical cancer, or you have colitis, or you're older, or you're heavy, or you smoke or you drink. And then there are other things about decreasing risk, like you get a lot of exercise, you take aspirin, or these things called NSAIDs. I took part in one of those trials in which people were given high doses of an NSAID. And it really did decrease the risk of getting colon cancer. But it caused a marked increase in cardiac disease. And they had to stop the whole trial early because the risk turned out to be worse than the benefit.
I have a question. Where did you get hormone replacement therapy? Because I tried very hard because of my menopause, and it's very for women. I don't know.
This is an old slide. Back in the day, a lot of women got hormone replacement
But they
therapy.
destroyed that.
Right. And the reason they destroyed the program is because they didn't destroy it totally, but they now don't recommend it because even though there was benefits to the woman in terms of the vagina and right and not having sweats and flashes and whatever, the risk and dryness and itching but the risk of having a stroke went up.
That's very tough for that. Because I'm into that and
Right.
Well, I got somebody that I'm working on, thank God. Because
All
I
right.
always ask. And it's
All
very-
Yeah.
Does MRI count in the same category?
No, MRI is not radiation. MRI is magnetism. Radiation is something different. Radiation is like an atomic bomb. No. No. Well, unless you have like an artificial hip or some metal, and it's like, doing an MRI on somebody with metal is like putting some metal in a microwave. You know what I mean? And that is like you shouldn't do it, right? So, what's that?
Doctor, they didn't tell me that. I won't everybody do it.
All right.
That's why they asked you. You had just passed the slide, and I didn't see it, but I just wanted to make sure. Have we seen any correlation between people with HIV positive or had C positive cancer?
I studied HIV and screening colonoscopy to see if there were increased numbers of cancers and polyps compared to non-HIV, and the answer is no. Now, HIV people may get Kaposi sarcoma. They have an increased incidence of lymphoma. They have an increased incidence of cervical cancer. They have an increased incidence of anal cancer. They have an increased incidence of any cancer that seems to be related to an infection like the kind you can get when your T cells are low. But not others like breast or colon or prostate. That doesn't seem to be related. So, Jacoby. Jacoby's a safety net hospital, just like North Central Bronx. And a safety net hospital is a hospital that serves two different kinds of populations. There's one population, usually working class, who come to clinic, and it's their hospital and their doctors. And then there's another in which is anybody comes to that hospital if they need it. All right. You have a seizure, in the subway, 911 is called. You go to a place like Jacoby. You don't go to Mount Sinai, you don't go to Montefiore, you don't go to New York Hospital. You go to Jacobi, you go to Bellevue, you go to Metropolitan, you go to Kings County. They're the safety net hospitals. And they'll take care of you. We'll take care of you, regardless of whether you can pay or not. So, a group of residents came to me, 1999. We're interested in colon cancer. We decided to look at it. What we wanted to do was like, doesn't matter. Because just as we were about to start in March of 2020, COVID came and we had to shut down. All right. So we picked it up again in November. And there we decided to try to predict who was most likely to have incurable disease. And we did as much as we could by looking at the charts to try to look through what was on that chart I showed you before. Age, sex, race, weight, whether or not they were our patients or just showed up, whether they had a screening test or a diagnostic test, whether they had screening colonoscopies before, whether they smoked, had diabetes. And then we looked to see whether they were advanced or not. So about half the patients were our patients and half just showed up. A minority were found during screening. And a smaller minority actually had been going for colon cancer screening. And then when we looked, it turns out that what's going on in the rest of the country, not that much different. So our experience is the same as other people's experience. And just like that other slide I showed you, for the people who had screened, most of the cancers were not advanced. Whereas the people who didn't get screening, who weren't actually part of our clinic, they showed up advanced. And the reason's obvious. How are you going to get a screening exam if you don't have a doctor? And why would you come to the hospital unless you're sick? And that's the explanation.
Dr. Collins, do you have any insight on the racial demographics of this thing? Because it seems to me that, you know.
Next slide. Next slide. Next slide. Yeah. All right. And a slide 3 or 4 or 5 beyond it. Let me go through it and then I'll break and take some questions. All right. Now we did some statistical analyses and like, you shouldn't care. But it turns out that if you happen to be a Jacobi Clinic patient or NCB and you underwent screening, you are more than 90% protected from coming in with incurable disease.
What kind of screening?
What's that?
What kind of screening did you say?
Well, when we were doing it back then, it was called colonoscopy.
Oh.
All right. Together, if you were, you were a clinic patient and you had screening. I mean, if you were a clinic patient and you refused to be screened, well, then your risk wasn't any lower. But smoking didn't matter, and your age really didn't matter, and whether you were diabetic or heavy, none of that mattered. What mattered is like if you got screening. All right. And even though you may have an increased risk, so what? If you're screened and the polyps are taken out, well, then you're okay. But you could be eating good and holding your weight down and getting a lot of exercise, and you still got colon cancer if you weren't screened. Okay. All right. So there's a group called SEER, which is a national database. About 50% of the 50% of like the nation. And then there's Jacobi. And the two on the left are age range of people with cancer. And you see what it is over on the left side of the graph?
Under age 20, 20 to 34, 35 to 44, 45 to 54, 55 to 60, etc. All right. And in both,
65 to 74 was the peak. And the average for everybody was 63. All right. You look at the right. Jacoby had somewhat more women than men. The rest of the country had somewhat more men than women. Look at race. And you can see the rest of the country had more white people than Jacoby and NCB. But the rest of the country had enough, enough diversity. And then you look at disease stage. And again, over on the left is like localized. Over on the right is where it's spread. And you can see here, the national database had more localized than Jacoby did. But if you look at distant, which is this stage 4, which is truly incurable, 21%, 20.9, 21%. Hardly different. There was more spread to the lymph nodes in Jacoby than the rest of the country. We could do better. The rest of the country could do better. All right. Give me another 3 or 4 minutes and then I'll break. So the National GI Association had a statement on the future of screening. And they finally caved and said, one size doesn't fit all. We can't get by just offering colonoscopy or nothing. Because 25 to 30% of people will not have a colonoscopy and they're at risk for colon cancer. And it's not getting better. We got to try to make these non-invasive tests as good as we can make them. We have to try to look and try to understand who is most at risk. Because the people who are more at risk should be tested earlier and more frequently. The people who are really not at risk should probably be tested less frequently. And then the final one, which is in yellow, and I'm going to spend more time in a few minutes on it, is that we have to do shared decision making. We can't just tell the person what we want them to do. We have to try to educate the patient so they can make an informed decision about what is best for them. Okay? All right. So once we finish that, around that time, Jacoby started offering the stool test. All right. And we decided to look at that to see how they did in terms of did we get it to them? Did they actually go through it? And if they were positive, did they have a colonoscopy? If they had a colonoscopy, did we find polyps and tumors? And then for the ones who didn't do it, we went back to the chart to try to figure out why. I said that if the test is positive, you really should follow up with a colonoscopy because you're at a higher risk. So of the 2,400 specimens, 174 were positive. And most of the time we ordered a colonoscopy. There were some that just never got ordered, but 80% or more, we ordered the colonoscopy. But in the people that we offered the colonoscopy, less than half agreed to it. And by now it's better because we kept after him and after him and after him. Now, normally, if we're doing colonoscopy to look for cancer, if we find cancer like 1 every 500 procedures. But in the people who had that positive test, we found it in 11%, more than 1 in 10, 55 times higher. Advanced adenomas, the ones I said that were really big and we're pretty sure would turn into cancer. Normally it's 4 or 5%. We found 20%. any adenoma, which people say should be around 30%, we had 60%. So the test does what it's supposed to do. And the ones who were negative, they had hemorrhoids, or maybe we didn't look, but they could have ulcers and bleeding from ulcers or heartburn. I mean, but we knew that it wasn't colon cancer. And then we looked at the chart to find out why weren't these tests done? Was it something that we didn't do? Was it something that, what happened? And the patients refused. 80%, the patients just refused. How could they refuse? Unless they didn't know what the implication was. Unless they thought that the choice was either, well, have a colonoscopy or give a stool specimen. So we conclude, and then we looked at screening and diagnostic to see whether it was any different. It was no different. A positive test is a positive test. So we concluded that FIT is a real promising tool, but we got to educate people. We've got to get them to understand what a positive test means. So this is the most important slide of the whole presentation. It comes from a health system called Kaiser Permanente. You may have heard of it. And they got interested in colon cancer prevention around 2000. And they spent several years educating people. And around 2006, they started offering stool tests or colonoscopy, whichever you want. And between 2006 and 2018, the number of people who are up to date went from under 40% to over 80%. And the number of people with cancer went way down. That's not the best of it. They did another analysis, and they looked at non-Hispanic whites and non-Hispanic blacks. Both groups had that same increase. And then they looked at who had early stage cancer, late stage cancer, total cancers, and death from cancer. And what you can see is that the red line is higher than the blue line. And sometimes it even there's a white in between. What that means is that the non-Hispanic blacks had more cancer than the non-Hispanic whites. Significantly so. That is a health disparity. But look over at the right side of these graphs. By 2018, the two lines came together. So the conclusion is that, yeah, there's a health disparity, but it doesn't have to be. And if you can get people to get tested, if you can get people to get screened, you can prevent their cancers. And early on, they actually had an increase in the number of cancers as they found more. And then after that, it went straight down. And not only did it go down, the people with late stage cancers went down more than the people with early stage cancers. But much of that decrease in incidence came from people in whom their cancer was prevented. And that's the best of all. So now I need your help. But before that, anybody want to ask a question?
When you talked about cancer last time, how about anal cancer? Is that related?
That's something different. I'm looking at colon cancer. And we specifically excluded the people with anal cancer.
Any, my nephew.
By the way, it's the same. That anal pap smear, and you should probably talk about anal pap smear like cervical pap smear.
Okay.
right? And in both of those, if you do the screening and treat early, you can prevent. But this is colon cancer.
That's colitis, and he was very young, like, you know.
He had what?
I don't know, think it like colitis, how you think it?
Diverticulosis.
Yeah,
Diverticulosis.
yeah, it's explosive, it's like.
Of diverticulosis.
Yeah,
Yeah, that's not colitis.
and a colonoscopy at a young age, about 12 or 13.
For diverticulosis
Yeah,
that's- or diverticulitis, but
you
usually,
know what he had, that's
yeah.
why.
That's really young. You usually see in people ages 50 and 60, although recently we've been seeing in a lot of people ages 35 and 40. But that's an inflammation of a diverticulum, and it's not colitis. It's not a chronic colitis. It's an acute infection. And it's really, that's something different.
That important presentation is need data, maybe too soon, we need data about COVID and people who got vaccinated, non-vaccinated, and
Colon cancer?
there's any correlations with incidents and any patterns, you know,
I don't know anything about COVID and colon cancer.
on whether they have factored, I guess, maybe too soon, but I think it's a good idea to factor the whole COVID thing, vaccinated, non-vaccinated, and long-term COVID, whatever, and what vaccines they got and what reaction they have had to the vaccine in relation to diseases like cancer.
Not done.
Yeah, they did find correlation with heart diseases.
Yeah, but the correlation with heart disease is very rare. It's very rare. Okay, it's not like 20, 30, 40%. It's like 1 in 10,000, 1 in 50,000, something like that, 1 in 100,000. And it's real, but it's not common at all.
It seems to be a racial thing where more Americans and more American males had issues with heart, you know, or stroke problems. Either after the COVID, or after the
Yeah, that's something different. This is a talk about colon cancer.
yeah. That was good. Is any correlation with it?
No, not that I know of any correlation with colon cancer. Yeah, Scott.
Yeah, I'm not gonna make too many excuses for them, but due to incompetence and due to overcrowding, like with the stool test, when you're at a certain age, you have to risk. You need to specifically ask for this test through your provider, correct?
Well, yeah, except the provider should be specifically asking you when you are due. Just like you shouldn't have to ask your provider that when it's time for a mammogram. Provider tells you.
Well, I agree with what he said. Because fortunately, when it comes to color, yes, it is what he said, and then they don't educate you. Because sometimes when they like the sample that you gave for the do the test, and we say that I will get applied to me for a lot of things. The hormone replacement question that I asked, and then they don't want to educate me. And I say, I don't know, I'm naive, I want to understand, and they don't care. I think it's something.
I understand, but that's really something different. And if I have to try to defend people, it's the only thing I can say in their defense is that they got 15 or 20 minutes. They got a lot of things to get through, including writing all this stuff up. And it's been studied, the amount of time that a regular doctor in a regular clinic visit has to educate somebody is like 2 minutes. Who? But wait, but who? You could say somebody else, but who else knows?
Somebody that knows.
Well, yeah, but like, who are they and where are they?
Well, you said that when was the claim. You see, I asked a lot. When they told me about you, and I know that when doctors will respond to care, but a lot of people they don't.
Yeah. Yes, ma'am.
I'll tell me though, no matter how much I talk to them, it gets to the point that if people they did, diabetes, and he could get my brother, I could be, that's smoking, changing that, he didn't, AIDS, that's just, my brother did, you know, the ABT thing.
You go back to patients, the doctor.
You talk about my family thing, just saying, family history, how do I know my family history? When you discuss these things, you know, they don't listen, they used to the point that not only don't listen, now they tend to have to fight.
Once again, that's a different. That is a,
And I think you'll agree, even though I don't usually see it because I'm not there, that this problem of lack of trust is deserved. It doesn't come out of nowhere, right? What I'm saying is that it's something different. It's something that I'm not here to talk about. And it's important, but I don't know what I'm going to do here to change that. I'm here to talk to you about colon cancer and even more to get to this part where I need your help to help us do it better.
You know, we've heard a lot about chemotherapy. What is the treatment for if you were diagnosed positive with colon cancer? What's the treatment?
Well, the treatment. The treatment is to cut the cancer out, to do surgery. If they can't get it all out, if it's spread, then it's chemotherapy. But most chemotherapy is what's called palliation, which is not curable, but you try to relieve the suffering, extend life, but not a cure.
With the colon, you just go in and take it out.
You go in and you take it out, all right? And the really early ones are now, people are learning how to take them out with an endoscope. So you may even prevent having to have surgery, but if it's small enough, people have learned how to cut deep and cut those out without making a hole in the intestine.
Yeah, thank you, Dr. Kotler, because to me, I see, man, you know, that lifestyle and choices of what we eat have more of an impact on our colon than something that's genetic. You know, I know for a fact that even myself, as a Black man, you know, I had this innate fear of not only a prostate exam, but a colonoscopy. It took me a moment to go on to the side and get it done. And I'm glad I did. But, you know, a lot of us have been stigmatized.
So-
we have
so
this
tell me.
innate fear
Tell me, you had it done.
of the test.
Was it a problem?
Huh?
You had it done. Was it a problem?
No.
Right
And
now, what was the worst part of the whole test?
the worst part
Yeah.
was the physical, you know, for the prostate, a man, you know, checking out my prostate. What's the worst part?
I was actually talking about the colon.
Oh, the colon?
Colonoscopy, and
The
more
worst
than
part was
anything
being
else,
put. The worst part was the anesthesia for me.
yeah, most people say the worst part is the day before when you don't eat and then you have to drink this stuff and sit on the toilet.
No, that was
Right.
no problem.
Well,
I remember being kind of painful afterwards. I couldn't exactly sit. It was kind of painful afterwards. That was the worst part for me.
you have an animal doing it?
No, Gloria, y'all picked me up from the hospital after my colonoscopy, didn't you? And I said I didn't want the pain medication, but you made me take it. I'm glad I took that pain medication. But I'm just saying that was the worst part. I'm glad I did it, but that was the worst part. But like she said, the preparation for her was really bad.
Yeah.
But for me, it was just I couldn't sit for a day, like a day or two.
I was just gonna say, yeah, and when I had mine done, like you said, you have to drink all that stuff, use the bathrooms. But since I've had mine done, when I go to my doctor and I said, oh, is it time? They said, no, because like you said, 10 years. They said, nope, not. So I'm not ready for my next checkup, but it wasn't that bad. I didn't find it that bad.
Someone said the magic word was pain. And the reason why I had my colonoscopy was because I had an inguinal hernia, and that was the most painful thing. I flip cars, I get hit
got pistol whipped, hit with baseball bats, sticks, billy clubs, nightstick, whatever. But that inguinal hernia was the far worst pain. And they said, well, you have to have there was another test before the colonoscopy. I forget, I can't remember the name of it now, but it's a type of screening test. So I had to have that and then the colonoscopy. And that pain from that hernia was so bad that I couldn't wait to have that dealt with. So I would have taken any test. Now that I'm not in pain, that's been what, 11 years ago. So I guess I'm due, but pain is the motivator that got me to take it. And I don't know, I it's not a priority to me now, but if I was in pain, I would go.
All right, so let me go on. I just have a few more slides I want to show you. Because as I said, I need your help. The one thing that we're not seemingly doing very well is educating people. All right? Heard that from you. You heard that from me. I think we all agree. So, damn it. So New York City and a whole lot of people have come out with these brochures and videos and whatever. And they all kind of look like this. They look like a comic book. And they actually have the information, fourth most common, and what are polyps, and who might get it, and how old you got to be, all the stuff that I said. They have a little bit more on symptoms, but these are the things. And then they talk about the stool test and all that. And right down here, this little tiny thing says, if your stool is positive, you might need a colonoscopy.
But I don't know.
All right.
But as an African American male who is educated, that doesn't feel like a comment.
Don't worry, but let me finish because, all right. And then if that's not bad enough, they say, well, you can eat well and not drink and get exercise and stop smoking and lose weight. But far and away, the most helpful thing to do is to have a test. All right. So I have an alternative approach, and it's what I talk to people about before I ask for consent to do the procedure. But shit, these guys have already, they've already done a prep, they've already signed consent, they've already talked to their doc, they've already come. So that's not a regular person. Those people are primed to get done. So, but this is how I would want to talk to somebody if I were to do it in clinic. If I were to make a podcast and make the people in clinic listen to it. Well, many people say, well, if I feel good, why should I have a colonoscopy? I feel okay. Well, if you feel okay, you have no symptoms, and we find the cancer, 90% chance of cure. On the other hand, if we don't do anything and then you get symptoms, and the symptoms come from a colon cancer, it's less than a 20% chance of cure. All right. And the risk goes up as you get older, and it starts out benign and then can turn into cancer. And if we can find and remove those polyps, we can prevent cancer. Let me finish. Now, the two major ways are colonoscopy and stool tests. To prepare for the colonoscopy, you got to change your diet for a couple of days, sort of less vegetables. And then the day before, drink clear liquids and then take a purge. Once you go into the hospital or you go into the office, you get some pre-medication, either enough to make you like high as a kite. We use fentanyl and Versed, which is kind of like heroin and Valium. Or some people get propofol, right? So it's like, all right, so, but you could say, well, fentanyl can kill you, but yeah, so can propofol, but not when it's done right. So the stool testing is, like I told you, just looking for the blood or genetic material. But if that result is positive, then you need a colonoscopy. Negative, you just have to repeat it. So the choice is not between a colonoscopy and a stool test. You can start with the stool test But if it's positive, it means the risk of having a cancer or one of those polyps that can turn into a cancer is very much elevated. And then you need a colonoscopy to find it or rule it out. And if you find it, you can get it staged and whatever. So if you have a cancer, let it be an early one. And this is another important slide. Any screening test is better than no screening test. And any screening test for colon cancer is better than just quit smoking. Quitting smoking is a good enough thing to do, but not for colon cancer. Getting tested is, and whatever one you choose, that's the best one. Best test in the world is like not helpful if you don't do it. The one you do is the best one there is. Well, what do you think? Oh.
That's the way I.
Well, no. That's not what I'm not here so that, 25 or 30 people will get tested.
Then what's gonna happen?
So what should I do? Should I give people the comic book? Or should I make a podcast with that alternative approach? Do I try to make it like not scare people? Or do I take that risk and talk to people looking at them in the eye, face to face, and tell it straight?
Yes,
Which?
like the last. That's for me. Face to face.
Tell me, no, I'm not gonna answer your question. You answer my question. What's the better way to do it?
Face to face and telling it straight. And the podcast, like I said, I don't know why I don't identify with that comic book. And there's another thing, the elephant in the room. And I don't know why, Dr. Cutler, but it's just true. African American men always have issues about whatever got to go up our butt. You got to make it clear. You
think that Latino men?
Well, okay, men in general. No, you got to make it clear. This is a health thing.
And you know what?
This has nothing to do with
And you
your
know what?
sexuality.
White guys are not too thrilled about it either.
Well, so I'll change that. You have to let men know that this has nothing to do with your sexuality. This is about your health. Could we get it stuck in our head? I was working at Harlem Hospital and I wouldn't let Monica Shaw, I wouldn't let her do it. I wouldn't let Dr. Lau do it because I had to see him every day. I worked with him. Well, I did go to the Ralph Lauren Cancer Center, but that's not the point. And I'm a healthcare professional. And I wouldn't let them do it. So you have to get through the men that it's a health
You
thing.
didn't let them do it, but somebody else did it.
I went to
That's
Ralph
all.
Lauren.
No, hey,
That's me, but
if I see a religious Muslim woman,
yeah,
she won't let me do it,
right.
but she'll let a female do it. I don't care. Just get it done. All right, as long as you get it done, get it done. If you don't want me to do it, I'm cool. Just get it done.
What will make you more
If I would have known that it was more about my health than my sexuality, because like I said, being a healthcare professional, I've known you for 20 years. When she said when she gave me the stool test, the second time I went back, the nurse tried to do it. I thought she was giving me the stool test because she thought I was having anal sex. I just found out all this time she was checking me for cancer. Had nothing to do with anal sex.
Did you ask
So,
her?
No.
did she tell you?
No.
She should have.
Right.
That's the point.
But that's the education part. Yeah. Yeah, because like I said, the second time when I went back after my appointment, she didn't do it. The nurse said, "Oh, well, I'm going to give you the stool test too when she do my blood work." I said, "No, I don't need it."
Well, I don't want to say from me, but like if the given is that they're not gonna ask you, your health is still the thing that's most important. So shouldn't it be on you to raise the question as to why you're not gonna do it?
You know why? You know what's surprising? That's not the first time. I'm 65 years old. The stool test might be a little new. I've been told. People have asked me about colonoscopy. That's the first time a provider put a stool test on there about me asking. Well, I've been in your for 30 years.
And where was
Nobody
that?
ever asked me for
Where was that? At Harlem?
AHF. New young girl.
Oh, okay.
She's
So
yeah.
I don't know about that, but I do know that every year, when I give a noon conference for the interns and residents, I use these slides.
Yeah.
All right, and they should know. All right, and if you saw that slide from Kaiser Permanente, it took 4 or 5 or 6 years before finally they felt comfortable enough to really push it, and that's when things got better.
But what scared me is, I knew from working at Harlem Hospital 20 years, from knowing you, from knowing Gloria. What about people who don't do this kind of stuff? They gotta be worse off than me. How are we gonna get through to them well, like I said, one way for all men, tell them it's about your health.
Are you talking about doctors? You're talking about people.
Good people, community.
You know what that, you know how you get around that? Outreach.
Hey, that's what I
Hey,
do.
how did you
I
do
do.
it with Hep C?
Outreach.
You stop people on the street. We talked
Damn
about
right.
Hep C, right?
Right.
Well, I wouldn't necessarily stop people on the street. You know, but right, but maybe Coke can do something about that. Maybe you can find people where they are and go to them. You can't expect the hospital to do it because if people are too busy sitting in clinic or on the wards trying to keep people from dying, that there's just not enough of them. All right. And if there's not enough of them and the information is simple enough, well then let non-medical people learn and do it. I mean, you did it for hepatitis C, you did it for HIV, you probably should do it for hepatitis B. David Yale was here. Gilead was here.
You know what, they have a lot of health fairs going around,
Uh-huh.
and I think they should show up, just like HIV and hepatitis. They should have people from different cancer groups coming out to the health
Good.
fairs,
So,
because a lot of people
so-
like health fairs.
so who here lives in NYCHA? City Health Housing? Nobody?
Irrelevant project.
No, it's NYCHA. It's New York City Housing Authority. Well, it turns out that in Manhattan, there are more than 100 buildings of NYCHA housing. Right, and in the Bronx, there's another 80 or 90. And in Queens, I think there's a bit fewer, but in Brooklyn, there are a lot. So it's like 400 to 500 buildings, NYCHA housing. And every one of those has a common room, and every one of those could handle a health fair.
Oh, yeah.
Right. And that health fair could be the outreach.
Centers.
We did it.
I didn't mean to bring that up, but
Program, all of them, they shall be programs to do it, and they'll be getting less educated and all shall be programs.
and
Well, I just want.
anybody here in Amita Care?
About programs that you attend, right? So.
When you run an organization, you really try to do as much as you can, but your funding will direct what you put more effort into because that's what you have funding. So let me just say that that's one of the reasons I always wanted COPE to be the way it is and not funded by companies or agencies that want me to do what they want me to do. So therefore, you can't get this much money because you won't do this, right? So part of what I feel Don is saying is this is a problem, and we did a good job with HIV. We did a good job with Hep C, but these are not the only things people have. As a matter of fact, HIV and Hep C people are doing pretty okay compared to other things. So remember I told you the storytelling and how we can use it to change policy? You could say to somebody, you know, I used to feel like I didn't want anybody to know about my HIV status because the stigma. It's the same thing with colon cancer or colonoscopy, whatever it is. You can give someone an analogy that shows the same thing in where they're at. Because HIV is not their story, or drug use, you don't know, right? But you know that if you live in a certain way, you're more at risk for a million things. So I guess one of the things we could do is continue to put this on our radar conversation when we talk to people, because I'm sure we do a lot of good talking about there's prevention for HIV now. You could take a pill, right? Like anything we know, we share. So you want to share what we did today. But Dawn left, and I want to make sure we give him, his props because he wanted to do this talk last year, remember guys? And he, he had he had his own episode and getting sick for a minute, and we finally got to hear this and we want to take it forward. So just to let you know, we are trying to get a grant to do education in NYCHA. We won't be able to do 500 buildings at once, but we will pick a couple of buildings or 5, whatever we decide that we can manage. And in those buildings, we have to study the project, right? So that means we'd ask 50 people and we try to study the ones who say no and the ones who say yes, and look and see about intervention. In this case, a colonoscopy and all those other things would be, right, the things that we do in terms of talking about as prevention. And then once people, we have linkages, we have like we have something to offer that most people, you guys take for granted. When you have a doctor, I didn't have a primary care doctor until I got HIV. And I didn't even know that's what it was called. Right? I mean, I didn't go to the same doctor every day, every time I got sick as a kid. I went to Cumberland Hospital. So the concept, right, wasn't there. So just saying that just because we've learned something, we can't assume everybody has that. And also, because our HIV is good, or we got rid of our Hep C, we still got to look at other things and go get the screenings for. I mean, I did this heart thing. It was disgusting. 3 different things. But now I know my heart is strong, So it's like that. That's important. Okay. Anything else, Kyler? Just let's give him a hand. Tell him how much we love him.